Alright, now let's get down to brass tacks and talk measures of association, with the first being odds ratio, also known as relative odds. Generally speaking, the odds of an outcome is equal to the probability of that outcome occurring divided by the probability of it not occurring. For example, the odds of rolling a 3 on a standard 6-sided dice is 1 to 5, which we can calculate by dividing the probability of rolling a 3, 1 over 6, by the probability of not rolling a 3, 5 over 6, and this comes out to 1 over 5, or 1 to 5. Keep in mind that the odds is not the same thing as probability, which in this case is 1 over 6 and corresponds to risk. The odds ratio, like other measures of association, communicates how likely an outcome or exposure is in one group of persons relative to another. However, unlike relative risk, odds ratios are a lot less intuitive since they cannot be converted into probabilities or percentages. Although odds ratios are commonly associated with case control studies, other studies, including cohort studies and even randomized controlled trials, will sometimes report results with odds ratio. Odds ratios are useful for rare diseases since, due to the relatively large proportion of unaffected persons in the population, their outputs approximate relative risk. However, because odds ratios always overexaggerate the risk or effect associated with independent variable, their use should be limited to case control studies. Nevertheless, we will look at their application in cohort studies as well. For cohort studies, the odds ratio is calculated by dividing the odds of an exposed person developing the disease by the odds of an unexposed person. More important than calculating the odds ratio is understanding how to interpret it. Odds ratios are tricky little rascals. For a cohort study, the odds ratio communicates the odds of an event occurring in the exposed group relative to the unexposed group. If odds ratio is greater than 1, the results suggest that exposure increases the odds of developing the disease and thus is positively associated with the disease. An odds ratio equal to 1 implies that no difference in outcome exists between exposed and unexposed groups, and thus no association is suggested. If odds ratio is less than 1, exposure decreases the odds of developing the disease, negative association, which may indicate a protective factor. So for example, if the odds ratio of a particular exposure outcome association is 3, we can say that a person exposed to that exposure has 3 times the odds of developing the outcome as someone who is not exposed. However, we cannot say that an exposed person is 3 times as likely to develop the disease as someone who does not have the exposure. And as we'll see in a bit, the conclusions that we can actually make depend not only on the value of the odds ratio, but also on the associated p-value and confidence interval. Now for case control studies, we calculate odds ratio by dividing the odds that a case was exposed by the odds that a control was exposed. The conclusions we draw are similar but not the same as those for cohort studies. We can still make the assertion that if an odds ratio is greater than or less than 1, an association exists between disease and exposure, but we have to be careful how we word it. For case control studies, the odds ratio communicates the odds that cases were exposed to the exposure of interest relative to controls. If for a case control study the odds ratio is 3, then we can say that compared to controls, cases have 3 times the odds of having had a previous exposure. We cannot say, however, that exposures have 3 times the odds of becoming cases as non-exposures. Now let's take a break from conceptualizing and look at some real-world examples. So for our first real-world example, a group of radiologists conducted a study to look for associations between specific preoperative CT findings and the presence of an appendiceal tumor. They did this by separating participants into 2 groups, those with the tumor and those without. Then, they reviewed the preoperative imaging to see how frequently certain findings like fat stranding and appendiculus were present for each group. So question 1, what type of study is this? Now let's pretend for a second that they didn't put case control study in the title. In this study, researchers begin with a tumor group and a non-tumor group, and then they look back to see which CT findings were associated with an appendiceal tumor. This method of starting with cases, persons with tumors, and controls, persons without tumors, is characteristic of case control studies. Alright, so question 2. Which measure of association is most appropriate to communicate the strength of association between specific CT findings and the presence of an appendiceal tumor? And let's pretend for a second that odds ratio is not the only answer choice we talked about so far in this video. Because this is a case control study, odds ratio is the only reasonable option. Hazard ratio is used for survival studies, while risk ratio can be used for cohort studies and clinical trials. Although sensitivity and specificity are terms used to describe imaging modalities like CT scan, The information given in the description of this study details a search for which CT scan findings have significant associations with appendiceal tumors. And since specificity and sensitivity are not measures of association, they cannot be used for this purpose. Interestingly, however, the authors did use their findings to create a diagnostic scoring system, which they then described using sensitivity and specificity. But we'll talk more about this in another video. Moving on to question 3, what are the odds that a patient with an appendiceal tumor had mural fat stranding on CT? Pause it now if you'd like to give it a go. So based on the table, 52 patients in this study were found to have an appendiceal tumor. Of these 52, 39 had fat stranding on preoperative imaging, meaning 13 of them did not have fat stranding. The odds that a patient with an appendiceal tumor had fat stranding on his preoperative CT scan is 3 to 1. Now for the odds ratio, we crunched some numbers and come up with 0.42, which, assuming statistical significance, tells us that patients with appendiceal tumors have 0.42 times the odds of having fat stranding on their pre-op CT as those without tumors. We can also say that patients with an appendiceal tumor are less likely to have had mural fat stranding on preoperative CT scan, but we cannot say how much less. Here's another version for those who want some more practice. Alright, now let's have a go at interpreting the results. Question 5. Which of the following is a valid statement based on the information in the table? Answer choice A. Appendiceal neoplasms cause mural calcifications. So this may be true, and the table does show a statistically significant association between mural calcification and the presence of an appendiceal tumor. However, observational studies, like this one, cannot be used to support a claim of causality. Answer choice B. Patients with fat stranding on preoperative CT scan are 58% less likely to have appendiceal tumors. Okay, so the negative association between fat stranding on preoperative CT and the presence of an appendiceal tumor is statistically significant. However, there's a few things wrong with this statement. First, this is a case control study, and it cannot be used to estimate how much more or less likely an outcome is based on an exposure. Second, by using the phrase 58% less likely, the statement is attempting to describe an odds ratio using probability, and that's just straight up not cool. What we can say is that patients found to have appendiceal tumors after an appendectomy are less likely to have had fat stranding on preoperative CT. Moving on to answer choice C. Relative to patients without appendiceal tumors, patients with an appendiceal tumor have 0.23 times the odds of having had an appendicolith on preoperative CT scan. So this is actually a correct statement, and it implies that there is a negative association between appendiceal tumors and the presence of an appendicolith. In fact, the authors went on to list appendicolith as a quote-unquote protective factor. Also, one cool thing about odds ratios that is not true of risk ratios is that the reciprocal number is true for the reciprocal statement, meaning that we can also say relative to patients with appendiceal tumors, patients without an appendiceal tumor have 4.35 times the odds of having had an appendicolith on preoperative CT scan. This special property of odds ratios is referred to as invariance to labeling of events. Lastly, answer choice D. There is a significant association between ileal wall thickening and the presence of an appendiceal tumor. So the odds ratio associated with ileal wall thickening is 1.18, which at face value suggests a positive association. However, when we look at the confidence interval, we see that it includes the number 1. That is, it includes the null hypothesis of no association between ileal wall thickening and appendiceal tumors, which would yield an odds ratio of 1. This indicates that the association is not statistically significant. Also, the p-value is equal to 0.0684, meaning there's a 6.84% probability that an odds ratio of 1.18 was obtained by chance or due to randomness. Keep in mind, it would be incorrect to make the conclusion that there is no association between ileal wall thickening and the presence of an appendiceal tumor, even if the odds ratio is exactly 1. This is because even though an odds ratio of 1 suggests or indicates that there is no association, it is still very possible that an association exists, but our study is simply not powered enough to detect it, which would be considered a type 2. Moving on to our next study, a group of ER doctors set out to investigate which factors in the initial ED course of acute diverticulitis are predictive of outpatient management failure. They did this by taking a group of 693 patients, making note of demographics like age and gender, labs like white blood cell count, and treatment decisions like the duration of prescribed antibiotics. They then followed these patients for 60 days to see who among them suffered treatment failure, which they defined as a return to the hospital for acute diverticulitis. Alright, so question 1. What type of study is this? Because the study establishes potential risk factors at the outset and follows a group of patients over time to see which develop disease and which do not, this is a prospective cohort study. And even though no strict control and study groups are delineated, we could think of the presence or absence of each risk factors as a delimiter. So with respect to leukocytosis, those with white blood cell counts under 14 are controls, and those with white blood cell counts over 14 are the study group. Question 2. What is the odds ratio of treatment failure in patients with initial white counts over 14 relative to those with initial white counts under 14? For this question, we calculate the odds ratio like so, and obtain an odds ratio of 0.7, which can be interpreted as patients with a white count of over 14 have 0.7 times the odds of experiencing treatment failure of outpatient management as those with a white count of under 14. Or, simply, patients with a white count greater than 14 are less likely to experience treatment failure than those with a white count less than 14. We can say this because this is a cohort study and because we're not using numerical descriptions of probability when interpreting this odds ratio. Lastly, question 3. Based on the table, which of the following is an accurate statement? Answer choice A. Compared to men, women are more likely to suffer treatment failure of outpatient management of acute diverticulitis. So this is a correct statement. The association between being female and suffering a treatment failure of outpatient management is statistically significant and greater than 1, indicating that compared to males, females are more likely to suffer treatment failure of outpatient management. Answer choice B. Women cause diverticulitis. This is a tempting conclusion to make, I know, but remember that observational studies cannot be used to prove causation. Answer choice C. Having an initial white count of over 14 is associated with a statistically significant decrease in the odds of treatment failure. As we can see from the p-value and confidence interval, this is obviously not true. In fact, according to the p-value, there is a 97% probability that the result was obtained completely by chance. Answer choice D. There is a 32% probability that antibiotic treatment for over 10 days is significantly associated with a decreased odds of treatment failure. Okay, so this is an attempt to interpret p-value for antibiotic duration. However, since the p-value is 0.32, we say that there is a 32% chance that the results were obtained at random and no significant association exists, while there is a 68% probability that association between antibiotic treatment for over 10 days and a decrease in the odds of treatment failure is not due to randomness. However, given the significance level of 0.05, 68% just doesn't cut the mustard.